Welcome to Monash Tech Talks, the privacy paradox, data sharing in healthcare. I'm your host, Rachel Pannett. Let's begin by taking a moment to acknowledge the Gadigal people of the Eora Nation, the traditional owners and custodians of the land on which I'm joining you today, and the Wurundjeri and Bunurong peoples of the Kulin Nation, which our panelists are joining us from. I pay respects to the traditional owners and elders, past, present, and emerging, of the lands that we are each meeting from today. Over the next hour, we're going to look at data privacy in the context of healthcare, where patients will often reveal their most sensitive details, and where providing the right information could mean the difference between life and death. Today, we have four very exciting panelists joining us: Professor Chris Bain, Adjunct Professor Naomi Dobroff, Dr. Chee, and Karrie Long. First up, Professor Chris Bain is the inaugural professor in practice in digital health. He is a seasoned clinician and a respected IT and information systems specialist with more than 25 years experience in healthcare, including 12 in clinical medicine. He focuses on the usability of technology and works with universities and companies around the world. We also have Adjunct Associate Professor Naomi Dobroff. She's the Chief Nursing and Midwifery Information Officer at Monash Health. And she has an extensive clinical career and is currently the healthcare executive responsible for leading and advocating for over 7,500 nurses and midwives in the appropriate implementation of clinical information systems that enable the provision of care to Monash Health patients. We have Dr. Chee joining us all the way from Singapore, where he is Chief and Convergence Scientist at Smart Health Leadership Centre at the National University of Singapore. Nicknamed the consultant's consultant, Dr. Chee brings more than 20 years of experience in health informatics, digital health, innovation, technologies, and business. And we have Karrie Long, the Director of the Nursing Research Hub at the Royal Melbourne Hospital. Karrie is a human-centered designer and self-proclaimed possibilitarian, a mindset that does not accept limits unless they're constructive. She uses both of these valuable skills to improve the design and adoption of new innovations in complex systems within health, most recently telehealth and nurse-led research at the Royal Melbourne Hospital in Australia. Now, we might start with a broad look at the general state of play in data sharing in healthcare in Australia. We live in an increasingly digital society where people are accustomed to thinking about privacy in the context of social media or in banking, or even in terms of the data that companies collect on us for targeted advertising. But we're less familiar perhaps with what information is available in terms of health data and what practitioners are able to see when they come into an ED. So perhaps, Naomi, you can kick us off with the question of what is interoperability and how big an issue is incomplete information in healthcare?
Thanks, Rachel, and thanks, everyone. It's lovely to be here. So, these are really complex questions to start off our day, but I'm really excited to tackle them with you. So interoperability is really around how we use and share our data. So different information comes from different systems, and we really need to be able to share that. It might be from a device, it might be from an application, but how do we bring that all together so that we can see various bits and pieces that are important? And in this instance, it's around our health journey and patients' health journeys. So it might be that information is exchanged, it might be that information actually is shared and becomes part of another record, but how that's done and where that's done is really interoperability. And when you look at HIMSS, as we all do, there's lots of ways of interoperability occurring, and so there's levels of interoperability as well. For us in healthcare in Australia, certainly we probably are at an early stage with our interoperability journey, because certainly a lot of our health services are still in early days with an EMR, if indeed we have one at all. Our GPs have been very good at adopting to digital systems, and a lot of our community and other providers, but the way that all sits together in Australia is complex. I'm sure you've all heard of the My Health Record and the way that's being used across Australia, but from a health perspective, certainly our patients think in many cases that we know more about them than we actually do. And so if a patient comes into an emergency department, if they come into Monash Health, we certainly know about them from a Monash Health perspective, but we don't necessarily know what's happened to them in other health services, at their GP. If they've gone to see a nurse in a community centre, we may not know about that, and it will really depend on that interoperability and things like My Health Record. Of course, I'm sure you will know we're still relying on things like faxes and paper in some of our organisations. And so again, that really plays into the complexity of our health environment. And so if you think about an organisation might have an EMR, we might have a scanned medical record for all of our paper-based documentation. We might have other clinical information systems, best of breed systems that are being used in specific areas. We may also have information that's coming from our GPs and from other external providers. And then, of course, we've got all of our test results, diagnostic imaging, pathology results. And so how that all sits together is really complex. And I know we'll pull that apart a bit today, but from an overview perspective and from what our patients expect, they often think as consumers that we will have the information about them, or at the very least, they should really only have to tell one of us once about something and the rest of us will know that. And I think that's what we all sort of expect as people in society, that we wouldn't expect to go through a journey in any organisation and have to say the same things more than once, but in health that is often still the case. And so I think that that breadth of complexity and the way our health system fits together with our sort of primary, secondary, tertiary centres makes for a really interesting journey, and definitely an interesting conversation around interoperability and how that all fits together in Australia.
I might take a question actually now from Gordon, who asked, how secure is the use of facsimile to transmit sensitive health information?
That is a great question. So I think most organisations are certainly trying very hard to move away from fax machines. How do we know where it actually ends up? And of course, it only takes one number wrong for that to not go where we want it to. So it's a really complex problem that we do need to, of course, move away from as we get more technological and being able to use other much more secure systems.
And now, Karrie, your clinical background is in rural ICU nursing. Can you tell us about some of the sort of unique challenges there in regional areas that aren't operating digital systems or are using a hybrid of paper and digital records?
Sure, thanks, Rachel. I think I have a unique view because I can see it from a systems perspective. I'm a board director of a regional hospital, as well as working in a large metro hospital who's just gone live with a rather large EMR. So what I see is, as we see with our consumers and patients as well, there's a digital divide in Australia on all levels, whether it's technology, human resources for the technology, infrastructure, funding. And so from a regional perspective, this is very much the case. So while large metro hospitals may have a great, be on their journey to optimising their EMR, smaller rural and regional hospitals might actually have end-of-life systems where they're at, and they'll be, you know, I can't speak for everyone, but there's a majority of paper and some scanned records. And so a bit like the fax, while we're risk averse to moving to the new system, our current system is actually very flawed as well. So we're in this paradox again of the challenge of there's risks of moving, but the risks of staying still are just as grand. And that hybrid systems require humans, and we know we're just as flawed as computers, perhaps a little bit more. to connect the dots. So it's really challenging in rural and regional environments where you have less people, less trained people in data security and technology in general, in builds, funding. So particularly in Victoria, there's always that challenge as well that we're often also working in different systems and using different brands. So just like some of us sitting here will have an iPhone and others will have an Android. So there's those challenges to manage as well. But definitely there's a divide that we've probably all experienced if you've gone for a drive up the Hume Highway for 4 hours and you lose connectivity. So that's kind of replicated in the clinical sense as well. And definitely, you know, our consumers will expect that if we're going to send somebody from one hospital in the country to the Royal Melbourne, that all that information will magically move across with the click of a button. But most likely that won't. That will be in an envelope. So we're in the new ages, I think.
Sure. Now, Adam, throughout your career, you've spearheaded many significant projects across Asia Pacific and the Middle East. How does the situation in Australia compare to elsewhere, and more particularly in Singapore, where you are now? Are you seeing similar issues, or are you sort of more or less advanced in terms of data sharing?
Well, yes. So it's actually pretty similar. Taking Middle East aside, because they are so rich, infrastructure is not an issue. Policy-wise, they are pretty flexible. But in Singapore, we're seeing very similar situation to Australia. The beauty of Singapore is we are small, so it's easier to get things done. So we have certain instances where, especially the GP, the primary care sector, we still use a lot of faxes, but we're trying to move away from that. The reason for slow adoption is actually legislation and not technology. It's more policy and legislation, because the question is who owns the data, which we'll go more into that later. But we have, fortunately, in Singapore, some acute hospitals who have done their EMR implementations pretty well. So they can obviously seamlessly access data within their own institute and institutes which they are actually closely affiliated to. But we still run across issues of trying to get complete data across all public health institutes. So the will is there, the strategy is there, the infrastructure is there. The technology is actually not an issue. It's really the policies and getting consensus that is more of the challenge for us here than other factors. Yeah.
Sure. Now, we might talk a little bit now about some real world scenarios of what happens when digital data isn't available or there's a breakdown in the chain. Chris, I think you've got an example there.
Yeah, thanks, Rachel. I just want to briefly mention or pay attention to what Naomi was saying about faxes that'll come up in this example. And also, as Adam says, you know, we now have means in different parts of the world to not have to use faxes anymore, to not have to share information via envelope, as Karrie said, through things like FHIR. So effectively, we're hoping that next few years sees a real change in this. But there's an example even from the Victorian coroner system, a case of about 3 years ago. I think, you know, people like Karrie and Naomi would recognise this could still happen today with the current infrastructure we have. But basically, a poor gentleman who was 58, so not elderly by any means, not much older than myself. He had lymphoma, which is a nasty kind of cancer. He was being treated in Melbourne and getting chemotherapy. One of the potential side effects of the chemotherapy was damage to his lungs. And he went back up to the country, to a country hospital to continue his chemotherapy. Presumably he was from that area. Just before he left Melbourne, though, he had a CT scan of his lungs, which actually showed that he was starting to get this damage to his lungs. And unfortunately, that result, so think of it even just a paragraph of text, was actually faxed to the wrong fax number. And so the treating team in the country hospital never got to see that. And they continued to give him chemotherapy, and the gentleman unfortunately died alone because of this. And basically, the coroner was quite scathing of this situation and basically said, how on earth are we still using faxes in today's day and age? I mean, I've said to people numerous times in this space, there are absolutely risks of transmitting information electronically, just as there are in paper, but this is a really good illustration, really, that it's pretty rare you end up in the coroner's court because you overshared information about a patient in the clinical setting. It's been a case in a number of instances over the years that these kinds of failures have caused a problem for patients. And a good metric is it's one of our national healthcare standards now about these transitions of care within a hospital, from a hospital to a GP, and doing them better because it's been such a chronic problem.
And what has COVID taught us about the need for and uses of data sharing? Could this sort of have some longer term implications for healthcare beyond the pandemic?
I think one of the interesting things of COVID, and I said this in another session last week, it's almost like a cultural jolt, right? So in the setting of we can't have people close together for their care, all sorts of things have happened that those of us working in this health information and IT space for decades have loved to see happen for a long time. But the barriers have been broken down through necessity. It's still not perfect, though. It's also highlighted that a lot of telehealth is actually just people calling on the phone. And there's all sorts of interesting things to dissect there. But I think it shows what's possible. It's basically, excuses have been sort of swept aside in the need to keep caring for people. And that's got major ramifications for how we do our jobs and for data sharing.
Sure. And Karrie or Naomi, have you got any examples there from your sort of clinical work where COVID has really come into play?
Yeah, I think it's really pertinent, particularly if we think about the contact tracing elements that we've had in order to control and trace the virus. There's a reasonable burden, balancing the burden for our consumers or the people sharing their information with those that are using it is a challenge as well. We had, in a second wave last year, we implemented a staff monitoring program where, we had hundreds of staff furloughed and we managed a team that supported them. So these people were also getting phone calls from the Department of Health because they were sharing their information around and track and tracing their COVID quarantine period. And there was an assumption even from clinicians within the health system that systems were talking to each other, and there was a frustration that why do I need to talk to you again around when I first showed symptoms or this, that and the other. And so for me, that was a really ever-present practical element of where we've still got some work to do, but there is this general assumption that, come on, get on with it, perspective.
Certainly COVID did help us. As you said, Karrie, got on with it. We all of a sudden had to move to telehealth models. We had to be able to use virtual conferencing for all sorts of reasons in health. But as you said, Karrie, I think it's really interesting that even our staff expected us to have that information about them. They expected us to know what was happening with them, and we, there would have been ways that we might have been able to do that, but certainly in the early phases of COVID, we were all learning and doing at the same time, and so I think it's been a really great driver. And now a lot of things we were wanting to talk about but haven't had the opportunity to. So, virtual care models and how we look after our patients in the community better, and how we support people when they go home from hospital better. All of these scenarios are now much more readily available to us with basic telehealth, a phone call, but also with other virtual ways of visiting people and meeting with people.
And that might be a good time actually to ask a question from Karen. who asks, wonders why my health is not used more widely, and from experience anecdotally from both patients and medical professionals, including at Monash Health. So why is it a complete failure? And has it got any chance of new life, I guess?
I think My Health Record probably had a false start in that it was an opt-in process. There was very little data available, and so it meant that it wasn't trusted by a lot of clinicians, particularly, but also what was the point when it was so limited in its use case. I think as time has gone on, and certainly again COVID being a driver, one of the things you can see on My Health Record, of course, is COVID vaccination status, and so it's really starting to shift that use case and the availability and accessibility of information that will become much more valuable, I think, and perhaps will drive much more usage of the My Health Record. There is certainly a place for it, and I think it's one of those systems that will, as it develops further and as it gets more information, will become more valuable and seen as more valuable by clinicians. But I'll be interested to see what others think.
Karrie, you have something to say there?
Thanks, Rachel. Look, I think there's a cultural element to that, and I'm sure everybody would agree. Having done some work with the Scandinavian countries that have a unique identifier for everybody in the population, and your information is kept in one place and accessible, and there is a societal element of trust around how this information is used, and it's got a lot to do with culture and government and the perspectives around how decisions are made about that. But perhaps COVID puts that on the table, particularly when we can't open borders and whatnot. It comes to a pragmatic element where we actually move past the academic discussion around our information and moves it to, but how are we going to move forward?
Yeah. Now, Chris, you've got your hand raised there. Well, you had something to say.
Yeah, thanks, Rachel. I think too, and all the points Karrie and Naomi have raised, absolutely true. There's a lot of, you spend an hour easily talking about the My Health Record at any stage of its life. I think there is moves afoot from a government point of view to get away from this perception that it was a file store of PDF documents, which was never actually quite true. But actually to move it to a place where elements of the data in there can be shared in the same way that we might do an internet banking transaction, right? So you can, as long as you enter the correct BSB and account number, you can send that money to anywhere else and you get a receipt that it's happened. That kind of really detailed data exchange paradigm, which will help with some of what's being spoken about. There's that kind of principle that sort of is underpinning the more modern technology approaches that we're alluding to for sharing data. So, really good examples. Anyone who's worked in an emergency department will acknowledge. Anyone who orders blood tests will have had scenarios in their life where simply because they could not get the hemoglobin result or the white blood cell count or the potassium result that might have been done outside the hospital 6 hours previously, they actually have to repeat the whole blood test because they didn't have that information. And no one blames them for doing it. I probably did that thousands of times myself, but it's a bit silly in this day and age where just having that information, which exists, it's real, but just not visible. There's also sort of side consequences. It just so happens my wife's going for some surgery recently because she's over 50. She needed an ECG or coming up for surgery. And, she had a conversation literally yesterday where the surgeon's saying, I've got the ECG, but I can't see the report. And by the way, this said you had it done a week ago. No, I just had it done today. And whilst that's a fairly trivial thing, it undermines confidence. So she's sort of going, well, I haven't had surgery with this surgeon before, and now they're not sure about the ECG. So there's all sorts of subtle impacts on people about not having, the information we think they should as healthcare practitioners.
For sure. Adam, have you got anything to sort of add there from Singapore in terms of the cultural issues and that kind of thing?
Yeah, we had similar issues. So culture is actually definitely a very important contributing factor. By larger norms, Singaporeans are very law complying citizens, but we are also very paranoid. So actually, I would like to raise a very good example recently that happened due to COVID. So we had contact tracing, where the government actually mandates the use of a specific device. You can actually download the app or use a token. And they made so initially when they were launching this, citizens were saying that, oh, you're gonna trap me. This is Big Brother watching me. But the government pushed ahead with the promise that the data would not be used for any other purposes other than contact tracing. Interestingly, there was a murder case that was solved by the pure fact that they were able to actually use that contact tracing data. And it was a dilemma because the government is saying that yes, we have the data. This is an exceptional case because this is a serious crime. And the nation was actually divided. Most of us feel that it's actually okay to share such data because I'm not doing anything really crazy. Yes, of course, some percentage are saying that no, this is invasion of privacy. And I took the opportunity to actually share that, look, for those of us who actually agree that such data can be shared, when we extend that mindset, aren't we being paranoid when we're saying that we don't want to share medical data? And it's towards the same line of train of thoughts, if you will, because no one's going to do anything really nasty to you. At least I don't think anyone's going to do something crazy to me. I'm not that important enough. And that applies to the majority of population in Singapore. Sometimes we think the issue. No one's really having hidden agenda with your normal cough, flu, CT scans, and what have you. And this is where the dilemma comes in. Although we are law complying, we can be pretty paranoid. And I'm seeing this trend across many cities in Asia. When I do projects in Korea, Japan, they have the same notion. Yeah, Big Brother. So on one hand, they feel that everybody should be sharing data because it makes their life easier. But when you go to them, would you share data? Oh no, hell no. Big Brother is watching. So it's really weird. And I think with the recent events that's happening, we're getting more connected online, and people realize the need that we have to draw that fine line of paranoid. So there is a possibility. So it's the possibility of an asteroid hitting Earth tomorrow and everybody dies. It's the same possibility. So yeah, we're getting to be more sensible. At least over in our side of the pond, we're starting to be more open and more receptive to conversations. Yeah.
For sure. This might be a good time to ask a question from Evelyn, who notes in the chat that even when we get rid of the fax and the issues there, that any type of data transmission or storage comes with a cybersecurity risk. Clinical data is obviously quite sensitive. And what are some of the non-functional requirements that you would consider mandatory for any transmission or storage method that is being considered?
I was going to say something a second ago that sort of touches on this, perhaps not as precisely as the questioner is wanting, but I think Adam's raised a really good point. And this came up in the My Health Record debate, and it's, this kind of forum is part of this, right? So people in the My Health Record debate, some of them would say really silly things, I thought, like, and sometimes they have to with their positions, like it's military grade encryption, and implying that no one can ever get access to this. That is simply untrue. And I think we're much better to have a frank conversation with people in the general population about the risks both of the current state and of the future state. And also where they have some power to decide that risk for themselves, to give them enough information to make those decisions for themselves. On one hand, if we end up in a scenario where patients, and I'm talking about, frontline healthcare in all its forms, if patients can routinely refuse the transfer of information from one care provider to another, then we will end up in a situation where patients will be asked to sign waivers that say you cannot sue me because you're not letting me have all your information to make an informed decision. And so, you know, that too is part of this whole conversation. You know, I've used this analogy before. I think it's true. I mean, we're basically in a war around information in every sense. And this is a societal issue. There are bad people who spend their lives trying to get access to information through computers. And there's a whole bunch of good people trying to stop them. And that just happens all the time. Just that the public's not aware of it until one day the bad guys win. And, you know, it's a bit like the footy umpire who makes a bad decision. That gets on the front of the paper. But what about the 99 good decisions they made? So I think it's more helpful societally to have this conversation. And these things are moving feast too, right? We might feel differently about it in another 5 or 10 years collectively.
Yeah, we have a question here about dynamic consent in the system, apart from, you know, sharing digital data and maintaining its confidentiality. Can you talk a little bit about the issue of dynamic consent?
I'm happy to talk about that kind of stuff and attribute-based consent. So for those not sort of familiar, I suppose we've had a scenario previously where you sort of broadly consent, right? Especially in the paper world. I'm broadly either an active or passive process, happy for you to have this information about me and use it, because it's in a wad of papers that big, it's a bit hard to do otherwise. Otherwise you start redacting things or taking them out of files. Whereas in the computational world, this idea that either I give you consent to use everything about my health status except my mental health conditions and my HIV status, for instance, or I only let my HIV status be known to the specialist who's treating me for that condition, who otherwise might look like an infectious diseases doctor. And equally, I want to change my consent. And there are, you know, paradigms legally around the world, which I think will come to us, where individuals can change that. They might consent to something one day and then withdraw it the next, computationally, because the systems let them do that. So these are all, if you like, much better fine-grained controls over consent. But again, if we come back to that clinical environment, it's potentially fraught if we get too much of that in that space. But it's an unresolved question for debate, I think.
We have a question from Annie, who says that increasingly there are situations where a patient will see their clinician for their clinical care, but may then see their clinician in a clinical research trial capacity. I think we talked about this a week or so ago. How should the boundaries of privacy and transfer of information be applied here?
Karrie, want to have a go at that?
I think COVID's shone the light on this in a ridiculous, and particularly in Victoria, if you think we had, you know, 1,000 cases in Australia, and we're in it, you know, in this new world of new science, we actually, you know, need to learn from this. So we've got these ethical debates around, if we don't use this information, how do we move out of this pandemic situation? And how do we reduce the burden on the participants? So, you know, say it was me that had spent some time in ICU with COVID, and there's a biobank full of the patients that may have allowed their information to be used for that. It's going to be a really interesting space to consider, and there's lots of things to manage and measure there. A little bit like, I think what we were just talking about, I was reflecting, I updated my phone over the weekend, and there's been some updates to the apps. And now when I open that app, it says to me, now, do you allow this app to track you when you're using it, when you're not? I have to really go through that process. So, you know, I think we reflected a week or so ago that our personal devices are far more advanced in their ability to manage, chronicle these nuances than our clinical systems. And, you know, health is behind in its digital innovation compared to banking, etc. But we still bring with it our, you know, do no harm aspect. So we've got to manage many aspects around our ethics, around what we do as clinical people. as well as what other industries can show us around how to move past that. So that's my contribution.
Would anybody else like to sort of add to that, sort of the differences there between the research space and the clinical space?
I just think that the bridge between the two is getting much shorter, and as Karrie said, we've seen this in COVID. We now, the reaction of the government around the use of Pfizer vaccines, for example, and who should and shouldn't get them, is directly related to that data that is coming out of other countries and our own, because the research cycle is so much faster, particularly in this current environment. So I think at times it's really difficult to actually pull apart how do we say, no, we're not going to use this data for research when we're in this cycle of needing to get ahead of the game, and particularly with our current environment. And there'll be other examples, past and future, where we are in a very volatile and very changing environment because we're doing, we're learning on the run, I suppose.
If I might just add, so I've come across some similar situations over in Singapore where we're doing research. And I think in general, people tend to lump research as one category, but it's actually different levels of research. So with regards to this question, it is the clinician who serves in the same, it's the same clinician serving in different contexts, capacity for the same patient. I think in situations like this, it will be at the late stage, and we really just have to trust our healthcare professionals that we really won't do harm to you. We will not deliberately do some funny stuff at that stage. So there are, of course, reasons for concerns at the earlier preclinical trial stages where you're experimenting, but chances of that we're doing it to mice and what have you, not humans. And when we reach out to the phase 3, phase 4, even phase 4 being the medication being launched to public, we're looking at a general reaction. I honestly don't think that any healthcare professional, if they're dealing with the same patient in different contexts, would deliberately choose a harmful decision. It's just not feasible. Yeah.
Yeah. Adam, this might be a good time for a question for you from Gordon, who says that since the large healthcare data breach experienced in Singapore a few years ago, policy and practice has placed extreme restrictions to what technology and solutions can be utilised. In some circumstances, this has proven to be counterproductive and prevented advancement of best practice data transmission and management. Do you foresee any change in government policy or mindset which would allow healthcare institutions and greater flexibility to implement better and more effective solutions?
That is an extremely good question. So I think the incident that's been referred to was the SingHealth cyber attack, which ironically was a human error. It was detected, and someone says, there's something funny going on here. I'm just going to ignore it for a while. And actually, there was a extended period where it was keep being flagged out. The guy didn't report it to his manager, and there was some data loss. But yes, there were detrimental effects. I think our institutes overreacted, even to now. So they removed non-essential internet access from hospitals. This includes rendering laptops without the ability to access the internet. You can't share files, but being public institutes, they have limited budget in terms of, let's say, email storage. So there becomes a dilemma when you try to do research, you try to share files, but you can't do it within using emails and whatever. So there's a series of complications that was just plain irritating. You have staff actually bringing their own laptops, subscribing to their internet access, putting it next to the work laptop so they can actually do real work. So yeah, the current situation is definitely not ideal. And as I mentioned, all these are really more policies. So what the government is trying to do is also find a fine balance where you actually ensure that it is secure and at the same time satisfy patients' perception actually. And we had a conversation with folks involved in that incident. Point number one, human error. And of course, number two is people say, oh, these systems are not secure. I said, that's not really true. If you look at Wall Street actually never goes down. It's using the same technology. But the difference is budget. So if you have enough budget to build a very secure system where you make it a very tight ecosystem, it won't ever go down. You don't see NASA systems going down where they are monitoring satellites and what have you. It's budget. So this is a very important point, because once you are not aligned to the root cause, you keep thinking it's a technology issue, you'll find imaginary problems with it. But if you acknowledge that it's actually a budget issue, then you have to actually question whether you want to invest. Again, it's a very fine line. It can be done. We put people on the moon before. We're not doing it anymore. Why? Because it's costs a lot of money. So same thing, it's a fine line. So definitely, in this case, back in context for Singapore, the government is definitely looking at a better way to implement things. But when we did root cause analysis, it's not a technology issue. It's how much are we willing to spend? So the same pool of money, the same bucket of gold, are we going to put it towards research or clinical care, or beef up IT systems to face imaginary threats, some of which could be real, but when we do post-mortem analysis, again, it's mostly human errors. Yeah.
Yeah, I think that's a really good point, Adam, and I'm sure Naomi and Karrie have seen this too. Risks around cybersecurity in hospitals, sometimes it's simply because the latest version of something hasn't been bought, or the antivirus software license was too expensive and we're changing vendors and there's a gap in the middle. Just a really good example from today, which goes to this whole point of having ongoing societal conversations. I'm on social media a lot for work. A meme comes up, says, name your favourite person born in July, right? Might be perfectly innocent, but it might not be. So as soon as I say Karrie's born in July, Naomi comes on and go, yeah, Karrie, happy birthday for the 25th. Suddenly we know Karrie's birthday is the 25th of July. Something like date of birth is critical to accessing information inappropriately. And we don't think about that. I saw another meme recently on this topic where people think, it's the risk in cybersecurity is some guy in a hoodie in a dark room doing this. But then they had a whole page of these things, right, where basically people are fishing for your information or information about those And if we think of that, then maybe we'll act a little differently when we use some of the platforms.
Yeah, for sure. So I've got a pot of gold for each of you. What are some of the new, let's do a bit of future forecasting here. What are some of the new areas for data sharing? Karrie, you mentioned a week or so ago a new regime for mandatory reporting of family violence information. How could this kind of data be put to use?
Yeah, I think, to some of us old clinicians that have been on the beat for 30 years or so, mandatory reporting came in maybe 20 years ago, and now in Victoria, as a result of the Royal Commission, there's the Family Violence Sharing Information Scheme, which is kind of taking it to the next level. And if I reflect on it, is actually about putting some processes and basically some decision trees around mandatory reporting. And I think it's come a long way into providing decision support and language and action for clinicians around suspicions or assessment around family violence. And it's a huge focus in our organisation, and particularly, in some hot areas in the emergency department and other spots. So I suppose I think the challenge for clinicians is keeping that in your forefront of your mind while you're also, caring for somebody or stabilising somebody at that same time. So I think the real challenge is moving these things forward, and it's great work in being brave and courageous, because this is an element that we do need to do, is brave and courageous and take a risk here, because the consequences of not moving, we've seen, are huge societal impacts. So we need to move it along, and I probably urge everybody to go and have a look at that document and have a look at around. There's some dynamic consent in there as well, and it's been done in quite a good way. So I think the challenge for clinicians is we'll be moving to lots of different components where we'll need to be sharing information for different principles and protections, whether that's research or something around this, around risk to our clients and to the public.
I'm aware of a couple of pieces of work going on in Australia, and we relatively lag in this area, but we're getting better. So I briefly mentioned a thing before called FHIR, F-H-I-R, which has been invented by an Australian guy, but has had a much bigger foothold in the States and North America because they have more electronic systems than us. And what they found is, if you look across their healthcare systems, they just ended up with the equivalent of piles of paper that they couldn't interchange, but it was electronic. And so this paradigm has been invented to do that. There's 2 projects in Australia at the minute, which once completed should have a major impact. One is looking at defining the data in primary care that makes, if you like, a neat summary of somebody's care and expressing it in this interchange format. So think of, I moved from my general practice in Melbourne to retire in Queensland. I wish, they're not yet, maybe one day. But instead of getting, the printout of all the documents or a CD with them all burnt, I actually can just have that internet banking type exchange where, I've seen it all, that looks right, click, and it goes to the person in Queensland. The other space I've heard of work going on, again, with a large national project, is in the residential aged care space. So what data describes somebody's residential aged care experience or bits of it. So that's also important because that's another big interface area for acute healthcare for hospitals, then with the people in these residential facilities. And often that exchange of patient doesn't always go as well as it could. So they're a couple of really exciting practical areas.
Mm-hmm. Turkey was a student at Monash for the past 6 years and had a health record there. But after the course, received all of their health documents in hard copy, left Australia and unfortunately lost them. So they have a question: is there any work to share data among multiple nations?
I would say yes. So there are initiatives in Europe where they're using standards, and they're moving towards FHIR as well. So now they're using an older version CDA. So the short answer is yes. But the real question is, when we're talking about sharing data, and we have a similar project in ASEAN because of the economic requirements to have free flow of professionals between the ASEAN state. And we came into the question is, what is important in Singapore may not necessarily be important data in, let's say, Malaysia, Thailand, and what have you. And sometimes it's tricky to get consensus between this. Again, it's not a technical issue. It's just a bunch of guys, really smart people, sitting down and saying that, yes, I agree with you that this is important, that is important. And not a situation where we try to go down to, yes, let's try to get everyone's requirements, because that's burden. So if you're asking for some really weird stuff that is not captured currently in that country, chances are no one's going to really want to invest in that. It's just pure financial. So yeah, once we get consensus like that going across, and you really need a mature or society to do that, because you have to say, yes, actually, I was wrong, or I don't really need this, because you're challenging the person's professional status as well. At times it becomes touchy. So again, the short answer is yes, there are initiatives all around trying to do that, but how effective that is. So if today, are there records being exchanged? Absolutely. Are they usable? No.
Right. We have another question for the audience about how can the healthcare sector better prepare for the continued use of artificial intelligence in the sector? Is a more centralized data sharing approach between states and federal health systems needed?
I think one of the things that these questions are making me reflect on just before we answer that one is really around data standards. And it's really difficult to share data if we don't have standardised, approaches to what data means and how it's captured and all of those things. So I suppose I just wanted to reflect on that and whether we're there yet, and I'm not quite sure that we are. So that's one of the things that, I reflect on when I'm thinking about any data exchange, particularly across other health systems. And then, of course, with AI, it's really important that the data we're capturing, that we're all describing the same thing, or that the data means the same thing across various places and across different jurisdictions or wherever we're sharing it.
Mm-hmm.
I think it's the sort of things Adam's just alluded to and I've mentioned are critical to the success of AI, where we think it's safe and valuable in healthcare. So, the old model was, I'll acquire all the data I possibly can from everywhere and I'll build the magical machine that gives everyone the answer. It's not really plausible. It's much better that, for instance, Karrie has an AI that best predicts my response to antibiotics in pneumonia. So I send her my age, some other bits of information and the chest x-ray findings, and she tells me what the best antibiotic is, whether Karrie is in Moscow or London or Melbourne. Likewise, Adam does the best one for analysing my ECG and telling me whether I've got subtle signs of a heart attack. That's the model that's sustainable, right? But it's premised on standardisation, as Naomi said, but also ability to share and in real time. There's no point me, emailing a request to Karrie and I get my answer in 3 weeks. That's not very helpful. So I think these sort of standards issues and interchange issues are fundamental to the success of AI in healthcare.
Mm-hmm. And Julie asks, she says it sounds like the adaptation and investment in health systems relates back to people's view and attitudes towards healthcare systems. And she asks, what can be done to change people's attitude and trust in healthcare systems? Perhaps a question for Karrie and Naomi at the coalface there.
That's a big one. I think I'd ask that of the audience, because sometimes I think as deep within the health system, we've got these very developed assumptions, and even as a human-centered designer that always tries to empathize with the other users, I don't think I'm the best person to answer that. I think trust is developed differently for different people, and that's really, really challenging. We can see that play out with the information around COVID vaccines in Australia. It's such a nuanced element, and we're seeing also the influence around, if I think more broadly around information and what power the press has to influence people's trust in systems, whether that was the My Health record or other aspects. I mean, I could get into, the free press in Australia, but I mean, these are big things to think about, but they do impact people's trust in the health system, their experience with it, the accessibility of it. There's many aspects to that, and maybe somebody else can contribute.
I agree with you, Karrie. I think it's a really complex question, and part of that, of course, is around your theoretical considerations around trust, but then often people's attitudes change in a moment of acute need, of course, and how that gets unpicked by society and by the way that we discuss these issues and the language we use and all of that complexity.
Yeah, I think Karrie's raised some good points, and so it's Naomi, and part of even universities' roles is to be hopefully seen as You know, we don't particularly care whether, I mean, it's not nice for the company, but whether a company succeeds or fails in the health information space, for instance. Like to think we can bring an independent voice about the facts and, you know, good or bad facts. You know, if you're in charge of a $2 billion government program to deliver something, it's very hard for you to be upfront and honest about it. Whereas somebody like myself or anyone on the call commenting on it from an informed perspective can give you some more honesty. You know, a really good example, right, is, you know, in that whole My Health Record debate, and I stuck my head above the parapet a couple of times around that. In summary, I thought it was sort of a necessary evil, really, right? That's my position on it. It's getting better. But people were saying insane things in social media about, you know, the government's going to get all your data and all things that just was so discordant from reality, like the fact that if you go to many hospitals in Australia, not all, but many, they do have electronic medical record systems with all of your intimate details. And the nature of these systems is that no hospital in Australia really is able to build, maintain and sustain those systems over decades. So they get private companies to do it. All legal, all known, all exactly what should happen. And those private companies hold all that data. So if you want to get nervous about people looking at your data, none of us are, because we know the reality, but go and look at what happens in those private companies. Don't worry about what some guy in Canberra is going to do, because that'll be closely monitored and they'll be frog marched out the door if there's a problem. So just really things that aren't you know, concordant with reality. So having messages and conversations and trustable advice is important. Yeah, I guess is my takeaway message.
Mm-hmm. And a question here from Anton: how easy is it to do data science? Is there an orderly process for managing and using anonymised aggregated medical data for medical research, other than for COVID-19, that is?
Maybe I'll add my 2 cents worth. So data science itself is easy. Data science with context is difficult. So you can actually run mathematical formula and it works out perfectly fine, but it can be absurd and not matching reality. So this is the problem, well, the challenge I find when we have students trying to do analytics and medical science, but they don't have a healthcare background. So they actually don't know the parameters, what makes sense, what doesn't, what are confounding factors. So from a mathematical point of view, you know, you run beautiful statistics, it matches out well. But you know, when a clinician look at it, says, what is this? This is not reasonable. So case in point, this is one particular newspaper article I showed during class to illustrate this. And again, this is published in a newspaper somewhere. It says that teenage pregnancy drops off when the ladies are nearing the age of 25. From a statistics point of view, that makes perfect sense. But teenage pregnancy should ideally stop by the age of 18. So once you cross 18, of course, by pure math, it goes down. So again, beautiful stats, but contextually just absurd. So if you translate this back to the medical setting, this is where I'm trying to illustrate it. A lot of times, you know, you run beautiful models and whatever it doesn't make real life sense. So data science is easy. Data science with context is a little bit more difficult. Yeah, a lot easier for finance, logistics, and what have you. For healthcare, it's a lot tougher. Yeah.
And Karen asks, is there a skills shortage in Australia of IT people who can set up effective digital health systems and maintain them? Or is it that the money to hire top IT people isn't there?
I think there's increasing pool of skills. Are they perfect skills? No, but there's an increasing pool of skills. Would I say there's a gross underinvestment in health information systems, health IT, versus what we need for the future? Definitely. You know, that plays out every day, but it's a bit like Adam says, you know, and this is a public conversation again, right? You know, if you've got a fraught health budget, because there's never enough money in healthcare, you could just keep pouring it in if you wanted to. Where do we as society want it spent? Do we want to sacrifice some of our care provision to make better IT systems which help care provision? Or do we just want to open, buy another scanner because there's a very immediate relationship to patient care? And we need to have those conversations because we always live in a finite world. None of us can reasonably expect, untapped budget. So I think that's the challenge here.
Karrie.
I will add there's sort of geographical shortages, as there is with all workforce in Australia. Our geography challenges things. The demographics of people that are trained and want to work in IT don't necessarily want to go and work 8 hours from the metro area and work on a project perhaps with a workforce that doesn't have digital literacy. It's really, really hard work, and then it's really, really fraught with challenges. And so, which are the same issues with our healthcare workforce as well. So, I'll always pipe up for the regional perspective, but if we want to have a healthy system, that we need to look at sort of both camps, but definitely from a regional perspective, there's a shortage in everything. Might be changing. There's been big tree changes post-COVID with people moving to regional areas, but in essence, that is an issue.
Yeah. Well, we're almost at time here, folks. We could really talk about this all day, I think, or even longer. But I'd like to thank the panelists, Chris Bain, Naomi Dobroff, Adam Chee, and Karrie Long for joining us today, and also to thank the team who organised the event. So thanks to everybody for joining.